Good afternoon to everybody. I am going to discuss one of the very important topic of hematology in pediatric practice, and that is about sickle cell anemia. We all know that hemoglobin is one of the most important connective tissue in the body. It comprises of cellular as well as humoral factors. The hemoglobin present in the red blood cells, they are responsible for most of the important function in the body, and that is in the form of transport of oxygen, carbon dioxide, as well as acting as a buffer in the body to neutralize the body's or the blood pH. So these are some of the important functions which the blood continues throughout the life, and it can be called as one of the most obedient fluid organ in the body, which works day in and day out and throughout the 24 hours in life. Now, how does this blood is carrying out the function? That is with the help of the hemoglobin. Now, what is this hemoglobin? Let us see. Hemoglobin is nothing but a chromoprotein, that means a pigmented protein which contains heme, which heme itself contains the iron, which combines with the porphyrins and gives rise to a heme molecule. Now, this heme molecule is attached to the globin molecule. Now, this heme plus globin gives rise to hemoglobin. Now, as it is being shown over here, the heme consists of iron plus protoporphyrins, and the globins, there are two pairs of polypeptide chains. These are the polypeptide chains, the alpha chains and the beta chains. So, two pairs of alpha chains and two pairs of beta chains, they constitute together to form a globin molecule, and globin plus the heme constitute the hemoglobin. Now, let us see how it is being produced. Now, hemoglobin is not a single molecule in the human being. It is of different types in embryonic life, in fetal life, as well as in the adult life after the delivery. Now, you see that during the embryonic period, yolk sac is the site of production of this hemoglobin, and that type of hemoglobin produced is known as embryonic hemoglobins, which contains the zeta polypeptide chains. Then we have got during the fetal life, the liver takes over the function, and the spleen also takes over the function, and ultimately the bone marrow. So these are the three sites of the formation of the erythropoiesis and the hemoglobin in the fetal life, and they have got different polypeptide chains during this particular life. Now, after delivery, we find that the bone marrow takes over the function right from the 4th month of fetal life, and it continues throughout the life. The liver discontinues as an organ of erythropoiesis or hematopoiesis after the delivery is over, right. Now, let us see, this same thing is being shown over here. Here you find that during the embryonic period, the yolk sac produces the embryonic hemoglobin, what is called as and consists of the Goer 1, Goer 2 and Portland. These are the types of hemoglobins which you get in the embryonic period, and they have got respectively different types of polypeptide chains. Thereafter, you find that the fetal hemoglobin, as we have seen in the previous slide, that the liver, spleen and then ultimately the bone marrow takes over the function. Here the fetal hemoglobin, that is the comprising of alpha 2, gamma 2 polypeptide chains, they take over the function. It has got a higher oxygen affinity, so that it can absorb more amount of oxygen from the maternal circulation and can deliver to the fetus. Subsequently, as the baby is born, after the delivery, you find that bone marrow takes over the function, and it is mostly the red marrow which produces the hemoglobin, and this hemoglobin is again of two types, that is hemoglobin A1, that is the main constituent, 90 to 95% of it, which comprises of alpha 2 beta 2 chains. The second one is alpha 2 delta 2, this is called as the hemoglobin A2. It comprises of only less than 3.5% in the postnatal life. So these are the important types of hemoglobins and their polypeptide chains which are synthesized during embryonic period, during fetal life, and during the later part of the fetal life and the postnatal life. Now, why we are so concerned? Because the sickle cell has got its relation with different types of hemoglobin and how they interfere with the symptoms and signs that we will see in a short period of time. Now, this is how the production of the respective polypeptide chains. The alpha chain starts right from the 6th week of postnatal life, gestational life. Then you have got a gamma chain, then the beta chain. Beta chain also gets started as early as say 6 to 7, and this is the important period which is responsible or which is important from point of view of the prenatal screening of beta chain abnormality, that is in the form of sickle cell. So therefore, we can detect as early as say 6 to 8 weeks of life the beta chain abnormalities in the form of sickle hemoglobin. Subsequently, after delivery, now this is the time when the birth occurs, the gamma chain go on getting lesser and lesser, and the delta chain also is very small amount, and the beta chain increases. The alpha chain is always at a higher peak, and alpha and beta together produces the adult hemoglobin, normal hemoglobin, which is 90 to 95%, and the hemoglobin A2, that is alpha 2 and the delta 2. These together constitute the hemoglobin A2, which is less than 3.5% in normal life. Now, coming to the how the hemoglobin production is being controlled genetically. There are two types of loci. One is called as alpha globin loci and second is a beta globin loci. The alpha globin locus is on the chromosome number 11. The chromosome number 11, and that is responsible for the production of the beta chain and gamma chain of two types and the epsilon chain, while chromosome number 16 is responsible for synthesis of the alpha chain. Now, the sickle hemoglobin is related with the chromosome number 11 abnormality, where the genetic loci responsible for the beta chain synthesis is located, and therefore, we get the sickle hemoglobin. Now, let us see in the subsequent slide. Now, hemoglobin disorders are being classified basically into two types. Number one is called as a qualitative disorder, where there is a mutation and there is a change in the amino acid sequence, and this amino acid sequence leads to what? It leads to decreased solubility of the hemoglobin. So, therefore, it goes on precipitating. Then there is a instability of this particular hemoglobin, and therefore, the red cells are easily destroyed. The altered oxygen affinity, for example, the fetal hemoglobin, which has got a high oxygen affinity, or the zeta hemoglobin, and the altered oxidation state of the heme coordinated ion. Say for example, methemoglobinemia, which has got a higher affinity for the oxygen and it keeps the heme in a oxidated state. Now, the severity of these particular different types of these qualitative disorders, collectively called as hemoglobinopathies, they are sickle cell SS pattern, sickle beta thalassemia, sickle cell and hemoglobin C, sickle hemoglobin and hemoglobin D, sickle hemoglobin and hemoglobin E, and different other types of hemoglobin. So, these are all different types of hemoglobinopathy. Now, quantitative disorder, there is a decrease and imbalance production of structurally normal globins. Now, as we have seen that there are pairs of polypeptide chains, alpha chain and beta chain. Now, one of the chain is not getting synthesized. So, that will result in a alteration in the ratio, and this imbalance production of alpha and beta chains, that leads to the thalassemias. So, these are the thalassemias. So, quantitative disorders are collectively called as thalassemias and qualitative disorders are collectively called as hemoglobinopathies. Right. Next. Now, this is how the sickle gene hemoglobin that is present over the chromosome number 11. Here the locus is defective, and that gives rise to defect in the base changes. And now, what is this defect in the base changes? At the 6th carbon atom or 6th locus, you find that this six, there is a change in the amino acid sequence. Instead of adenine, there is a thymine. So, this replacement gives rise to mutation, and so you get a sickle hemoglobin. Normally, you find that there is a adenine and thymine, guanine and cytosine, and in between adenine and thymine. Now, here this is a normal one, and in a patient of sickle cell, you find that the thymine is replaced by adenine, or adenine is replaced by thymine. So, this replacement gives rise to a mutation in the amino acid, and normally there should be glutamic acid. This is being replaced by valine. So, you get a sickle hemoglobin. Now, this presence of valine as an amino acid at the in this particular hemoglobin gives rise to a precipitation of these polypeptide chains, and these polypeptide chains, they get stacked together to form these sickle cells. So, hemoglobin S is the result of a single base pair change, thymine for adenine. So, thymine is replacing the in place of adenine. So, this type of mutation gives rise to a sickle hemoglobin. The sixth position in the normal beta chain has glutamic acid, while sickle beta chain has got a valine. So, valine is there, and polymerization of this hemoglobin under hypoxia, acidosis and hemoconcentration leads to the formation of a deformed red cell, what is called as a sickle cells. This is how the normal blood flows through the capillaries and the venules. They are able to get twisted themselves in the small capillaries and the venules, but abnormal sickle cells, what happens, these red cells, they are so deformed that they get stuck up. They are not easily flowing through the blood vessels, and therefore, there is a congregation or there is an obstruction to the blood flow, and that leads to what is called as vasoocclusion. And these change in the shape and vasoocclusion leads to the various types of the clinical features and the morbidity and the mortality in patients of sickle cell anemia. So, this is how the normal sickle cells, normal versus a sickle cell. Normal blood flows easily, while the sickle cells, they don't get, they are not able to say negotiate through the small vessels, and they get stuck up, and that leads to a problem. Now, what happens? These RBCs, they repetitively undergo sickling and desickling. This phenomena, when it continues for a long period of time, then what happens? There is a membrane of the RBC gets damaged. When the membrane gets damaged, the cation permeability increases. That leads to intracellular dehydration because the potassium gets leaked out, and the RBC becomes sticky, stiff, blocks the blood flow, and it leads to the vasoocclusive damage to the various organs, and there is a pain. Potent oxidants like superoxide, peroxides and hydroxyl radicals, loss of free heme, depletion of nitric oxide, endothelial dysfunction, vascular occlusion, complex interaction between RBC receptors, WBC, platelets, cytokines, vascular adhesion molecules and coagulation factors, they all culminate in patients of vasoocclusive crisis in a post-capillary venous, and if hypoxia and dehydration occurs, the acidosis results, and it ultimately leads to a vicious cycle. These are the various types of hemoglobin which I have already described, and the different types of amino acid sequence. Now, let us see the epidemiology. What happens to the epidemiology of these patients? You find that globally there are almost as high as 3.12 lakh newborn babies, they are born with hemoglobin SS, and about 1 lakh people, they succumb every year. In the United States, as has it is being said, the rate is relatively less, but it is very high in Africans as compared to the original Americans. In India alone, we see that almost as high as 2 crore people are affected, and the gene frequency in India is said to be as high as from 2 to 14% in a population which is, say, susceptible to this particular disease. In India, Maharashtra, particularly Vidarbha, the MP, Chhattisgarh, Gujarat and the west of Orissa, these are the states where we have got very high incidence of sickle cell disease. It is being said that it is as equal to that of a thalassemia, the incidence wise and the prevalence wise. Now, how this gene has erupted out or it has evoluted, it is being said that in previous days there was a very high incidence of malaria, particularly falciparum malaria, and these areas where falciparum malaria was very high, the nature tried to prevent the death out of this by creating a sickle gene, and this sickle gene was supposed to be responsible for preventing the death from malaria. Why? Because the sickle hemoglobin, these cells have got are resistant to falciparum malaria. The misshapen and the deflated red cells, they are the poor host for the falciparum malaria. Now, coming to the comparison in America and India, you find that the black population has got a very high incidence as well as Native Americans, while in India we have got tribal population, we have got Mahar, Buddhas, Gond and Pradhan, Satnami, Kurmi, Kunbi, Teli, Saho, Muslim, and even I have seen certain Brahmins also has got an incidence of sickle cell anemia in our Vidarbha and adjoining Chhattisgarh state. Now, what decides the severity of the disease? Because more the severe disease, more the morbidity and the more the risk of death. First of all, starting from the point of the type of hemoglobin, the SS, sickle cell homozygous, what is called as sickle cell anemia, that has got the highest severity. Then come the sickle cell with beta thalassemia. Beta thalassemia has got some amount of fetal hemoglobin, so it protects the hemoglobin from undergoing deoxygenation and therefore development of a sickling phenomena. Same thing is about sickle cell C, sickle cell D, and AS is nothing but a sickle cell trait which has got the least morbidity and the least pathology, and therefore they are almost as good as normal people. Now, apart from this, the other genetic and environmental factors are also responsible, and the genetic factors are haplotypes. It is being said that Asian versus African. Asian haplotypes has got a mutation in the alpha gene. So, there are 4 types of genes controlling the alpha chain synthesis. If one of that gene is defective, there is an increase in the production of fetal hemoglobin, and this fetal hemoglobin protects that particular person or a child from developing a sickling and vaso-occlusive phenomena. So, Asian are less severe than the Africans. That is one about the haplotype, the genetic part. Now, coming to the other factors like the hydration, if the child particularly in summer season or in the very cold season when the water intake is very less, the hydration, if it is defective or less, then patient can have the intracellular concentration of the hemoglobin increases, and that permits for sickling. Same thing is hypoxia, same thing is about acidosis, and same thing is about the cold weather, particularly in hilly station. If even a sickle cell trait person goes to a hilly station, he develops a splenic crisis, because that during that either there is one hypoxia because the oxygen tension at the say hill station area is very less, and therefore they develop a hypoxia, as well as cold weather, and that together culminates in to give rise to a precipitation of a crisis, what is called a splenic crisis in this patient, even febrile patients also. Now, coming to the other constituent, the hemoglobin S and hemoglobin F concentration and the viscosity. If you have got a child, there are suppose 5 children, and 2 of them they have got a very high hemoglobin, say around 9-10 grams, and the other one who has got only 6 or 7 grams, the chances of developing crisis is more in a child who has got a higher hemoglobin percentage than in a child who has got a lesser hemoglobin percentage, because the viscosity is less in a child whose hemoglobin is less, and therefore while giving a transfusion, this precaution has to be taken that he is not to be given a hypertransfusion. If he is given more packed cell transfusion, then he can have again a more morbidity. Same thing is the vasculopathy and nitric oxide. The nitric oxide is being depleted in patients of sickle cell anemia because of the various biochemical changes which we have seen just now, and that gives rise to the nitric oxide is responsible for vasodilatation. When nitric oxide is depleted, there is a vasoconstriction, and that leads to the many of these pathologies, including acute chest syndrome. Stress, infection, they are very well known factors responsible for severity of the disease. Now, what are the clinical manifestations? How do they manifest? The most common is a patient otherwise doing well, except that he has got a chronic anemia, which is present over here at the center. Then you have got a recurrent febrile illnesses because of infections, either bacterial or viral, then they have got a crisis. Crisis is nothing but a precipitation of a signs and symptoms in a short period of time, that is called as a crisis. Different types of crisis you get, and then a chronic organ damage, either because of chronic anemia or because of crisis or because of recurrent febrile illnesses, you get ultimately a chronic organ damage. Now, all these 4 factors are responsible for the total presentation, and that depends upon the age and the various underlying conditions responsible for these children. Now, coming to the febrile illness, it is a medical emergency. In a patient of sickle cell anemia, their immune system is defective, because the sickle patient, they have got a hyposplenism. Spleen is very much important for production of opsonins, and when the splenic function is deranged because of autosplenectomy, naturally the opsonization process is limited, and all capsulated organisms capsulated organisms like pneumococcus, the the salmonella and meningococci and Haemophilus influenzae, these are the organisms which flourishes in absence of opsonin activity, and therefore they are very much susceptible to this infection. It acts as a medical emergency because there is an increased mortality by virtue of this severe bacterial infection. Splenic infarction starts as early as by 6 months, and functional asplenia is seen in most of the children by 5 years of age. Streptococcus pneumonia, HIV and Neisser meningitis, indoor observation for 24 hours is justified if patient has got a febrile illness and waiting for the culture report. The risk of salmonella and staphylococcus osteomyelitis is very much there and may not be amenable to OPD management. Counseling of parents is important in these patients, and last but not the least, in indoor admissions also, ceftriaxone occasionally causes a autoimmune life-threatening immune hemolysis, and therefore when you are giving ceftriaxone for the first time, one should be very cautious while giving this particular drug. Risk of bacteremia requiring admission in febrile children with sickle cell disease. Seriously ill appearing child, febrile child where temperature is more than 40 degrees, the BP is low, the systolic BP less than 70 or 70 plus age in years into 2, or the CRT, capillary fill time, is more than 4 seconds. They are all indications. Severe pain, dehydration, a child who is dehydrated, end organ failure like renal failure, the lungs, the acute chest syndrome, the stroke, history of pneumococcal sepsis, and hemoglobin if it is less than 5 gram per dl, and the total leukocyte count if it is more than 30,000 or less than 5,000 per cubic millimeter, it is an indication that patient probably has got a serious bacterial infection, and the platelet count less than 1 lakh is also a ominous sign, and they should be admitted and given an appropriate care treatment after taking the culture. Now the vaso-occlusive crisis. Coming to the crisis part, the most common part which complications or the crisis which we come across is a vaso-occlusive crisis. Hand-foot syndrome or ischemic dactylitis is one of the common presentation where bilateral symmetrical swelling, painful swelling of the digits and hand dorsum of the hand. They are common in 50% by first 2 years of life. Long bones also may be affected in over the period, and even avascular necrosis of the hip joint or the shoulder joint, the abdomen, the chest, and even the penis. It is precipitated by physical stress, infection, dehydration, hypoxia, local or systemic acidosis, cold exposure, and marching or swimming for prolonged periods. Any person who is going for marching for a prolonged period, then he can develop this vaso-occlusive crisis. Treatment is again assessment. You have to assess the severity, then go for appropriate investigations. The mainstay of treatment is hydration. Hydration is the most important thing, and the treatment of the predisposing factors, and then followed by symptomatic treatment. These are the photographs of patient who develops the hand-foot syndrome. Bilateral symmetrical, the swelling, painful swelling, and if you take the X-rays of these patients, they show the necrosis, the periosteal, subperiosteal necrosis of the bones occur. Mainly the peripheral part more affected, because these vessels act just like a end vessels. This is another child of us who has got even the elbow joint being affected. The child is very much in agony. Another child, acute abdominal pain because of vaso-occlusive crisis, another problem. The fever, pain, guarding, tenderness, leukocytosis. Intestinal sounds sometimes are preserved, sometimes they may be absent or delayed. Abdominal pain, tender liver enlargement, jaundice, elevated enzymes, and that occur due to intrahepatic sickling or infarcts or due to cholecystitis. So, this is how a patient of sickle cell anemia presents with pain in abdomen. Differential diagnosis could be even as simple as, say, worm infestation. It could be appendicitis, it could be peptic ulcer, or it could be renal colic. So, whatever it may be, but in a known patient of sickle cell anemia, always suspect that this is probably because of the vaso-occlusive crisis. Avascular necrosis, most commonly the femoral head and mandible. The risk factors, they are again SS more likely with alpha thalassemia trait. If they have got alpha thalassemia trait, surprisingly they have got this particular necrosis very commonly seen. Frequent vaso-occlusive episodes and elevated hematocrit for patients with sickle cell anemia. Those who have got a higher hematocrit, there the occlusion of the end arteries becomes quite obvious, quite common, and therefore they have got a high chance. And these are more commonly seen in the beyond 10 years of age, adolescents who are active physically, and even after having a pain they do not take rest and their pathology go on increasing. The treatment is multidisciplinary, physical therapists, hematologists and primary care. Transient opioids, regular blood transfusion therapy has not been demonstrated. So, transfusion does not give relief to these patients, neither in terms of prevention nor in terms of cure. They only need a palliative treatment, complete bed rest, not to bear the weight, and well hydration. That is all what is being required in these patients. So, these are the various sites where you get the necrosis. These are one of our patients, the Jamburkar, who had this avascular necrosis. This is another patient. Now, coming to the neurologic complication, you have got these patients, they present with recurrent headaches and seizures. Occasionally, they have got transient ischemic attacks, they have got stroke, cerebral venous thrombosis, and occasionally they have got posterior reversible encephalopathy syndrome, what is called as PRESS syndrome. Psychosocial problems are there, rarely intracranial hemorrhage and retinal hemorrhages. More often they get occlusion than hemorrhages. Hemorrhages are seen in adults more often than in children, and that is probably being said that it is secondary to formation of a neovascularization around the old big vessels. Now, these neovascular vessels, they are very fragile and then they bleed, and when they bleed they give rise to either subdural hematoma or even intracranial hemorrhage. So, that is the main reason. Now, why you get thrombosis in these patients? It commonly affects the big vessels, either the internal carotid or anterior cerebral vessels or middle cerebral vessels. Now, how does it occur? Even in spite being a big vessel, the occlusion is because the vasa vasorum, the blood vessel which supplies this artery, that itself gets occluded, that interferes with the blood supply of the big arteries, and that perpetuates a problem of thrombosis and ultimately leads to this stroke syndrome. So, that is why we get the big vessels being affected in these patients. So, these are the slides which you find that as high as 30% of children with sickle cell disease has got a stroke. Some of them they can have silent stroke because it is not involving the motor area, the sometimes sensory or parietal areas, and more commonly seen in 5 to 10 years of age. This is how a child of stroke, they have got seizures, coma, neurodeficit, hemiplegia, hemorrhagic stroke rarely, PRESS and all those things that I have already discussed. Evaluation, clinical and hematologic and the imaging, these are the ways of evaluation. Of course, they need a oxygen therapy because oxygen is supposed to take care of the prevention of perpetuation of the thrombus phenomena. So, SpO2 should be more than 96%. Blood transfusion simple or within 1 hour it should be given, and the goal is that the hemoglobin should not rise above 10 gram%. It should not be 12 or 13. Do not go for higher because otherwise it will again perpetuate thrombosis. Exchange transfusion in certain cases to reduce hemoglobin S to less than 50 to less than 30% of that is the ideal one. And for press and central venous thrombosis, what type of therapy is to be justified is not being well known, well evaluated, and still an area of investigation. Prevention of strokes. The prevention is more important. A patient who has got recurrent headache, he has got a high chance, so he should be subjected for ultrasound, what is called as a TCD, transcranial Doppler study, and you have to find out whether the velocity is more than 200, or if it is more than 200, there is a high chance that this patient is going to develop thrombosis in future. Blood transfusion should be lifelong, or if patient has got silent infarcts. The goal is hemoglobin, yes, should be less than 30%, effective to reduce 85% of the overt strokes, and risk of blood transfusion is always there. So, it gives rise to alloimmunization, infection, and iron overload. So, these are the things which should be kept in mind when we are giving chronic transfusion therapy in patients of prevention for stroke. So, this is what the transcranial Doppler studies are done to find out the velocity at the origin of the internal carotid, the anterior cerebral vessel in the internal carotid artery. These are the areas of infarction, remote infarction of the territories of the left anterior cerebral artery and middle cerebral artery. And B is management, magnetic resonance imaging. Angiography shows the occlusion of the left internal carotid artery. And showing intracranial hemorrhage, and this is the infarct seen in this particular slide. Eye problems. Similarly, as we get in brain, same thing is in retina. The conjunctiva and the iris atrophy. Conjunctiva, you get a blocked vessels, what is called as corkscrew vessels, and retina you get neovascularization, there can be bleed and there can be detachment, and all these things has to be seen periodically, and if you have got a risk of retinal detachment, the laser therapy has to be offered. Acute chest syndrome, another very life threatening condition, younger babies 2 to 4 years of age, winter season, particularly this season, high hemoglobin yes, low hemoglobin F, high steady state TLC, total leukocyte count, and patient who has got reactive airway disease. These are the predictors of developing acute chest syndromes, and prodrome could be in the form of febrile illness, surgery, trauma, preceding surgery, trauma, painful events, and last 4 weeks. Infection, mycoplasma pneumoniae, chlamydia, and parvo B29 RSV infection, and other bacterial pneumonias, they are all associated and can give rise to acute chest syndrome. Pulmonary fat embolism, pulmonary infarction, bone pain, chest infection, they are all associated with acute chest syndrome. Now, when to call a acute chest syndrome? Acute chest syndrome is called when any new radio density is seen, X-ray has to be documented, and in presence of any of these two, either patient should have got fever, cough, chest pain, respiratory distress, or hypoxia. When any two of these are present in presence of a new radio density, then only you call that this patient has got a acute chest syndrome. The radio density could be in the form of a mild to extensive infiltrate with or without even a pleural effusion. Sorry. This is how the blood gets trapped in the interstitial spaces. Why it is going back? So, these patients' clinical features are cough, chest pain, fever, hypoxia, CNS abnormality, they may be obtunded, they may have got a normal chest because it is the interstitial pathology most of the time, and sometimes there is a wheezing. Investigations are the hematological, X-ray investigations, blood culture, and even the flu viruses, respiratory syncytial viruses, and ABG and echo study. All this has to be done in patients suspected to have acute chest syndrome. One of our patients who had this pneumonic patch and he had respiratory distress that time when he was admitted. However, we could salvage him. The frequent management is frequent clinical and SpO2 monitoring. Whenever patient is admitted with a fever, cough and cold, breathlessness, he should be monitored frequently clinically as well as SpO2 monitoring. Respiratory care, airway, oxygen, bronchodilators, postural drainage, and the pleural tapping in suspected cases. Analgesics, non-narcotics should be used. Narcotic has got a chance that the patient will get more obtunded, more drowsy, more hypoxia, more acute chest syndrome. So, narcotics should be used if at all with precaution if patient is already on ventilator. Blood transfusion and judicious fluid therapy. Over transfusion, that means over fluid therapy, the overzealous fluid therapy can lead to precipitation of acute chest syndrome. So, simple or exchange blood transfusion, progressive respiratory distress, and there is a oxygen saturation going down or work of breathing is increasing, then you have to go for a exchange transfusion. Worsening X-ray chest or decrease in hemoglobin 2 gram below the baseline or past history of acute chest syndrome, then only one should go for the exchange transfusion. Antibiotics as per the culture or third generation cephalosporin and macrolides. Bronchodilators, occasionally IV steroids, ventilator in hypoxic patients or who has got a respiratory failure. Nitric oxide therapy is definitely of great help in these patients. It acts as a vasodilatation, bronchodilation, decreases intrapulmonary shunt. It also helps in anti-polymerization effect and inhibits red cell endothelial adhesion, and therefore nitric oxide is very much useful. Course is unpredictable, but mortality could be as high as less than 25%. Repeated events, chronic lung disease and pulmonary hypertension is the end result of these patients. Death due to ACS is more common in adults because of the so many complications coming together. So, this is the acute chest syndrome before and after treatment. Now, renal disease and enuresis. You have got various types of renal problems or renal morbidities. They can have as simple as hematuria, papillary necrosis, nephrotic syndrome, renal infarction, hyposthenuria, pyelonephritis and renal medullary carcinoma. So, these are the various things which you get. More common what we see is a nocturnal enuresis because they have got a hyposthenuria. Their tubules get damaged because in the medulla, because of the concentrated urine, the tubules get damaged because of the vasoocclusion, because of sickling occurring more severely. So, this is what the histopathology of a kidney is showing. Priapism, persistent, more than 30 minutes, painful penile erection is referred to as a priapism. Adolescent and young adults 3 years to 20 years, 4 types are described, stuttering and versus refractory, but they are seen more often in adolescents than in, but we have come across one child who has got this particular priapism, and of course he was managed with conservative treatment. Supportive management is pain relief, hot water shower, aerobic exercises, analgesics. Definitive is for detumescence, and that is for prolonged episodes. Aspiration of the blood from corpora cavernosa, irrigation with dilute epinephrine, blood transfusion, exchange transfusion sometimes can be useful for relief of pain. Risk of acute neurological complication is there. Hydroxyurea and ethylephrine, these are other drugs which are being tried but with equivocal results. Sequestration crisis is one of the important complications seen in children, younger babies, because there is a sudden enlargement of the spleen. In sickle cell patients, 6 months to 2 years, as early as 5 weeks of age is being reported, and it is triggered by fever, bacteremia, viral infection, left-sided abdominal pain, and drop in the hemoglobin of more than 2 grams per dl, and hemoglobin less than 3 grams per dl, reticulocytosis and thrombocytopenia. The treatment is hemodynamic stability. So, isotonic fluid plus blood transfusion, 5 ml per kg Paxil RBCs, and the risk of hyperviscosity should always be borne in mind. Now, most of these patients, they die before they reach the hospital because it is a very real emergency. They go for shock, hypovolemic shock, and they die of this shock. Almost 50% of them, they die before they reach the hospital. Recovery with blood transfusion, fluid resuscitation is possible. Spleen regression within few days, and prognosis is pre-operative vaccination and followed by prophylactic splenectomy. Prophylactic blood transfusion, risk of autotransfusion, hyperviscosity, penicillin prophylaxis after splenectomy. These are certain ways of managing these patients. But what is important is that if a patient develops a sequestration crisis, being a life-threatening illness, these are the patients who should be subjected for splenectomy after being given the vaccination for pneumococcus and other capsulated organisms. Hyperhemolytic crisis, in tropical Africa you get such cases where there is a recurrent episodes of malaria which complicate the natural course of sickle cell disease, or sometimes patient has got alongside G6P deficiency and being given the antimalarials which can cause excess of hemolysis. So, fever, precipitous drop in hemoglobin, marked reticulocytosis and polychromasia on peripheral smear, and there is a unconjugated hyperbilirubinemia. Aplastic crisis, fever, precipitous fall in hemoglobin, reduced absent retics, selective erythroblastopenia, extensive bone marrow necrosis, infection with parvovirus B19 is said to be one of the important incriminating cause. WBC and platelets are normal or slightly subnormal. It is a self-limiting illness. Within 3 to 4 weeks period, their recovery starts, and most of the times they don't need anything except for monitoring their hemoglobin level and the hemodynamic status. Diagnosis PCR, IgM and IgG for the parvo B19, and risk of spread to pregnant caregiver should be borne in mind, because that can damage the fetus if the mother or the caregiver is pregnant and she contract the infection from this particular child. Chronic anemia, how do you find out? You get a hemolytic phases, you get a growth and development, puberty, everything delayed, personality, psychosocial development is being affected, academic and vocational limitations are there, systemic manifestations of chronic anemia can be there in the form of you get hemic murmurs or you get signs of congestive failure, and the CBC is usually normocytic, normochromic, and irreversible sickle cells may be seen on the peripheral smear, premature RBCs and retics are increased in these patients. Infections, the most common infections which are seen in these patients are capsulated organisms. They are pneumococcal, Hib, meningococcus, salmonella. These are the capsulated organisms where the infection risk of these infections is very high in these patients. Respiratory infections like swine flu and coronavirus, mycoplasma, they should also be borne in mind in view of the acute chest syndrome. Transfusion-associated infection like malaria, hepatitis B, hepatitis C and HIV, that also should be borne in mind along with the VDRL and all or the syphilis. And the bone infections like salmonella, staphylococcus and tuberculosis. All these types of infections should be borne in mind when you are taking care of a child with a sickle cell anemia. Chronic organ damage, you get varieties of organs being damaged either because of anemia or because of the crisis, and these are the spleen where you get infarcts, autosplenectomy, abscesses, infections is because of these organisms which we have seen. Cardiopulmonary system, the left ventricle, right ventricle, and they are enlarged, you get a pulmonary artery hypertension, you get cor pulmonale, bones and joints, you get the avascular necrosis, osteomyelitis, expansion of the facial and calvareal bones, long bones also, flattening and collapse of the vertebra, and genitourinary system you get hematuria, hypostenuria and nephrotic syndrome and priapism and impotence. So, these are some of the chronic organ damage which you get in these patients. Same thing about the liver also, intrahepatic sickling, impaction of the hepatic sinusoids, patchy areas of hepatic necrosis, engorgement of Cooper cells and biostasis, chronic liver disease, hemosiderosis, frequent blood transfusion, they are all responsible for the chronic liver damage. Growth is affected, the chronic leg ulcers are seen in adolescents more often in as high as 20% of the children. Sensory neural hearing loss is also seen, and proliferative retinopathy, vitreous image detachment that we have just now discussed. So, these are some of our patients who had this hepatic pathology because of the sickle cell anemia. Numerous sickled RBCs seen in bulging sinusoids. Another patient who had a very severe, her serum bilirubin was 42 milligram per deciliter, and however she recovered over a period of 3 to 4 weeks. This is another patient who was admitted with me. Today only I referred this particular child to the government medical college for the surgery because she had got a cholelithiasis with jaundice. She has got pain in the right hypochondrium, and genetic potential is very common. The age most commonly they are seen in child who are in between say 10 to 25 years or 30 years of age. less common beyond 30 years of age and less common before 10 years of age, and no sex difference, it is equally seen in both the sexes. Type of hemoglobin does not make much difference. Genetic potential is there. As compared to with reference to this child itself, her younger sister, who is herself a MBBS standard to MBBS 2 student, going undertaking education at JNMC itself, she herself has got a sickle cell anemia, and also she has got the cholelithiasis, but it is painless at present, and this particular child has got a very painful cholelithiasis, and today only I sent her for laparoscopic surgery to JNMC. So this is one of the child who has got this cholelithiasis. This is what the leg ulcers which I was referring to. Psychosocial complications are very commonly seen in adolescents. They have got recurrent school absenteeism, peer age group behaviors is abnormal, they do not behave properly, there is a bullying of this child, cognitive performance, scholastic achievements, and delayed puberty, they are all affected. Participation in sports and job opportunities are less. Quality of life is not good in these patients. Marriage counseling and depression and suicidal ideation, they are all psychosocial problems seen in day-to-day life in these patients. Differential diagnosis could be related to the symptoms with which the patient presents. Pertaining to chronic hemolytic anemia, then pertaining to vaso-occlusive crisis, pertaining to organomegaly, and pertaining to sickle cell anemia from sickle cell disease disorders, which are the various disorders which we come on. So sickle cell anemia, sickle cell beta thalassemia, beta plus thalassemia, C disease, and sickle cell trait. So you find that these two are the severe one, beta 0 and sickle cell anemia, HBSS, HBS, this is beta 0. So these are the severe one, their hemoglobin is between 6 to 9 grams. The MCV is normal in sickle cell anemia patient, but a patient who has got the thalassemia along with that, their MCV is low. Here also it is low because even though it is beta plus, but the MCV is low in this way. Here it is normal. This is how we differentiate. And they being severe, retic count is increased in these patients. So this is about, and sickle cell trait, they are asymptomatic most of times and they are got normal hemoglobin. Sickle cell trait, just one word about it, they are the carriers, but are they immune from morbidity? The answer is no. They also have got suffering. They can suffer from splenic crisis if they unknowingly go to the hill station or undergo a hypoxic condition, either even during the say surgery where the general anesthesia is given and oxygen is being not supplemented. Then they have got a hematuria, spontaneous hematuria. Renal cell carcinoma is seen very high in patients who has got a sickle cell trait also, and general anesthesia. The screening and counseling is very important. The problem is that the taboo with which it is being attached, and therefore the people they try to be away from the screening procedure. Diagnosis prenatal and the neonatal. Prenatal you have got amniocentesis, fetal fibroblast, PCR, sickle, and this is possible as early as 4 to 6 weeks of life, because the beta chain gets synthesized as early as 6 weeks. Then pre-implantation genetic diagnosis, maternal peripheral blood, isolated fetal cells can be taken for DNA analysis. Now neonatal screening, HB electrophoresis on cord blood, dried blood, or PCR amplification of DNA, and isoelectric focusing. These are HPLC. These are various methods of doing the test. The commoner one in older children which we do in day-to-day life is the clinical bedside lab, sickling test, the sickle solubility test. This is done for a community screening. Then HB electrophoresis, high performance HPLC, and the system appropriate test. Suppose for example various organs being affected, the tests pertaining to those organs they are to be taken care of. This is what the solubility test, this slide shows how solubility test can help. When the blood containing the significant amount of HBS is dissolved in a mixture containing a lysing agent, a high phosphate buffer, you get a deoxygenating agent. This HBS is precipitated and forms a cloudy solution like here. And as in tube on the right in this photograph, you find that you can't read these horizontal lines. Here this is a normal one, you can read the horizontal lines. So false negative test sometimes is quite common. This is about the electrophoresis. I will not go into details of it, but what is important is that the sickle hemoglobin has got a slow mobility, and so they are detected quite closer to the point of start as compared to the normal one. Same thing is here, sickle cell. This is about HPLC. Management. Management is multidisciplinary. Early diagnosis, what is most important, crucial from prevention point of view, from vaccination point of view, from counseling point of view. Parental education is important. Education for disease, education for complication, education for prevention and anticipatory guidance. They are all important because that only can take care of some of the anxieties and some of the pain of these particular families. Infection prevention and early treatment, hygiene, vaccine, drugs, blood transfusion not the panacea. In most of the places at say district levels, whenever a patient of sickle cell goes, they just go for giving a blood transfusion, but that is not the ideal method. That gives rise to lot many complications and they can sometimes become transfusion dependent because of the alloimmunization. So, better way not to give transfusion unless it is life saving. So, simple or packed transfusion, the exchange and automated is erythrocytophoresis. Risk versus benefit has to be always considered. Infection, immune induced and iron overload, all these complications should always be borne in mind when you are talking about this thing. Now, what are the definite indication of blood transfusion? Symptomatic and severe acute anemia, say for example sequestration, child is dying, he needs a transfusion, otherwise he will die of this thing. Hyperhemolytic crisis, same thing, and aplastic crisis for the time being. Then symptomatic severe chronic anemia, acute chest syndrome with hypoxia and prevention of recurrent strokes in children and pre-operative procedure. Suppose you are subjecting a patient to major surgery and in that case you have to give a transfusion before planning surgery. These are probable and not indicated, I will read. And what is important is that asymptomatic chronic anemia patient do not need a transfusion. Uncomplicated painful episodes do not need a transfusion. Minor surgery does not need a transfusion. Uncomplicated pregnancy does not need a transfusion. So, these are the things which should always be borne in mind because transfusion itself has got lot many complications. We already covered. Safe blood strict selection of patient and donors, selective blood and blood product transfusion, neocyte transfusion, pack RBC, triple saline wash RBC, these are various methods of collecting the blood for blood transfusion. Alloimmunization prevention, phenotypically that is antigen match, leukocyte depleted, iron overload, you have to give a chelation therapy. Exchange transfusion for blood transfusion associated infection. Complications of therapy, blood transfusion associated iron overload is very well known, infection is known, organ dysfunction is known and psychological stress and even the economic burden. What is needed is most common is hydration, hypothermia and hypoxia correction. That is, these are the things which are needed in 90% of the patients of sickle cell anemia. NSAID or opiates for relief of pain. Soda bicarb is only when patient has got proved acidosis, otherwise not. Blood transfusion if they are refractory, and hydroxyurea is always to be given in prevention and then treatment, and therefore it has to be continued throughout the life. One has to always keep in mind except during pregnancy. And as an add-on drug, another new drug is coming, that is what is called as L-glutamine. Pain relievers. What is most important, most crucial is a sympathetic approach to all these patients. This can relieve the many pain than any drug ever in life. So, this is very important. This can wipe the unseen tears from not only the child but also from the parents as well. Hydroxyurea is the most valuable adjuvant therapy and disease modifying agent. It increases hemoglobin F production, inhibits polymerization of deoxyhemoglobin S, reduces adhesive interaction between RBCs and vascular endothelium, and what is the end result is that it leads to neutropenia, thrombocytopenia and reticulocytopenia. So, we have to monitor this thing that the WBC count, the granulocyte count should not go below 1500, the platelet count should not go below 80,000 and reticulocyte count is to be observed or monitored from time to time. Is it effective in all cases? No, it is effective in reducing frequency and severity of painful crisis, VOC, which is the most common morbidity burden. Reducing frequency of acute chest syndrome is very useful. Reducing the need for frequent transfusions. and prevents damage to vital organs by preventing vaso-occlusive crisis. This is somewhat questionable, but at least to 50% it may be prudent. So, dose of hydroxyurea is as low as 15 to as high as 35 milligram, and monitoring for myelosuppression, CBC, hemoglobin F levels and pregnancy. What is the target point is that whenever we are giving hydroxyurea, we should see that the MCV of this particular child should increase beyond say 90-95%. If it is less than 95, then your hydroxyurea you are not giving, or patient is not taking it properly or regularly. Second thing, the hemoglobin level as well as the WBC and platelet count should not get lowered down to a very formidable level. This is what about the hematopoietic stem cell transplantation, bone marrow transfusion and or bone marrow transplantation. Either identical sibling donor, say monozygotic twins, or the sibling donor whosoever is available, or sometimes even the cord blood. Unrelated match, sickle cell stem cell transplant, umbilical cord stem cells, mixed donor host chimerism transplant. These are various types. They are still available for less than 0.00001% of the population. Because of the cost, because of the complications, it is not available for each and every patient. Indications for hematopoietic stem cell transplantation: matching of donors is very important. Genetically matched sibling has to be there. Risk of death, disease, 2-year event-free survival has to be there. And haploidentical transplantation has been tried nowadays, but with variable success. This is again in a experimental phase, gene therapy. Now coming to the prevention, various ways of prevention are screening, first and the foremost, antenatal, then the cord blood, adolescent and donor. All they should undergo a screening for sickle cell. In chronic organ damage, one should see for the transcutaneous Doppler, eye examination, iron overload, the lungs, renal and heart evaluation, education of the patient, disease, crisis, sequelae. Penicillin prophylaxis is to be given 125 mg twice a day for children below 3 years of age, because this is a drug which is easily available and which is say very effective also for control of pneumococcal sepsis. So, that is to be given. Immunization, national immunization schedule has to be followed. Hepatitis B, Hib, pneumococcal, influenza, meningococcal and even salmonella, the particular typhoid organisms. Nutritional counseling and fluid intake, psychosocial support and rehabilitation is very important. Genetic counseling, premarital, pre-pregnancy, prenatal, and these are and options whatever is there. Misconceptions, they are very much there. Misconception about the disease is there among the relatives, among the friends, among the teachers, among the insurance companies, and therefore, these are the patients who are not being benefited in most of the situations. This is what the counseling, premarital, preconception, prenatal has to be done, and they are to be taken in confidence, they are to be given in a very humble fashion. So, last but not the least is sickle cell disease is a common, severe, monogenic, lifelong devastating disease. It is a very common disease. The sickle cell hemoglobin polymerization produces pleiotropic harmful effects on RBCs, blood vessels and target organs, leading to miserable morbidity. Most of the deaths are in toddlers and in prepubertal children. Better understanding of the pathophysiology of the disease process and availability of newer treatment can improve the health status of these unfortunate children. Treatment is lifelong and costly. Prevention better than cure, and therefore, what is important is awareness, education, population screening and counseling. This is the bottom line of this today's lecture, that the awareness about the disease, education about the population, population screening and counseling, that is all what is important. So, and we know that the size of the problem is huge. Poverty, culture and ignorance, that is at the top of it, and resources are limited, and duration of treatment and prevention methods, they are all almost so duration of treatment is lifelong, and prevention of methods, screening and immunization, that is only easily accessible to us. So, give the best what is available with you. but there is a long way to go. The common public doesn't understand the importance of screening, doesn't understand the importance of the counseling, doesn't understand the premarital counseling and all those things. They consider it as a taboo, and they are going away from the medicos whenever their counseling is being done. So that is all about this particular thing. Thank you very much.